So I will talk today about the criteria for imaging and classification for traumatic brain injury in children and also spine injury. So you already heard that TBI is one of the leading causes of death and disability, and still there are no real guidelines, and if there are, they're used very variable in the whole world. And that means the diagnosis, treatment, and also the thresholds are always not clear. So first of all, you already heard something about mild TBI, and you can do the classification for the differences by clinical assessment, by mechanism, and also by imaging. But in the clinical routine, the clinical assessment actually is the most usable. And for that, you have to assess the child properly. And that means you really need an expert on the emergency room that can, it is very good in do a neurological examination of children, especially in the very young. So there is a popular and most used score in neurosurgery. It's the GCS, the Glasgow Coma Scale. And for children, it's a little bit different. You have to use and transfer the child's action into the score. And it is differently what age the child is. So you see here the different verbal and motor action, and then you have the number of the GCS. But never forget the parent's opinion. Even if the GCS is 15 and the parents say the child is not normal for them, they know their child best. Never forget that. But the definition of the TBI, there are three categories. It's mild, moderate, and severe. And the mild TBI is a GCS defined as 13 to 15. Brief loss of consciousness, temporary confusion can be present. And I just put here findings on the imaging. That's not the definition, but that is what we would expect in an MRI or a CT scan. So the moderate TBI is defined as GCS of 9 to 12. You have longer loss of consciousness, you can have longer confusion, memory loss, and you might find some abnormalities in the imaging. And the severe TBI actually is a somnolent comatose child with a GCS of 3 to 8. You have the loss of consciousness more than 1 day and significant memory loss. So in pediatric spinal trauma, the clinical assessment is also possible to do the classification. You have complete and incomplete, and for this, you look at the motor and sensory function and define if it's total or only partial. The mechanism is very important in spinal injuries because this actually triggers a certain pattern of injury. So if you know it's a flexion injury, you look at different parts. If you know it's a rotation injury, you actually know what to find in the imaging. And of course, the level of injury is very important. There is one very important difference in children to adults because of a very high head-torso ratio. The neck, the cervical spine, is the location of the trauma in more than 80%. But of course, you have also thoracic and lumbar injuries. So now, what to do when they come to your emergency department? There are many guidelines out there for imaging when and what to do, and they all differ. So I wanted to show you this systematic review just published last year in the Journal of Neurotrauma. It is a group from Canada, and they wanted to see if they get some recommendations out of these guidelines they found. And they, I think, found more than 300 to 400 and could include 15 in their study. And of these 15, 9 had a good quality. And for neuroimaging, you see it here, 3 they could find a recommendation. And these 3 all said you should do a CT scan of the brain if the GCS is lower than 14. And it was an Italian, an American, and an English one. And because the NICE is very nice, I wanted to show you the criteria. They put it very differentiated in the internet, and they have this task. They want to give guidelines for all kinds of different parts of medicine. And they divided their patients into children that aged below 16, and they created hard and soft risk factors. These are the hard risk factors, and if one of these is present, you should do a CT scan immediately. And they say you should do a CT scan, not an MRI and not something different. And you see GCS is always listed, and it's a little bit different if it's a child or even a baby, because in a baby, a GCS lower than 15 is already a hard criteria. And of course, differences to adults, you can palpate the fontanelle and focal deficits, and you have to assess the child very carefully. The soft risk factors are listed here, and if more than one risk factor is present, you also should do immediately a CT scan within 1 hour. And if only one is observed, you have to look for the child for more than 4 hours and use your clinical judgment to expand this period if it's needed. And for example, we always see the children vomit, and they say if it's more than 3 times, you should do the CT scan. So just keep that in mind. I think it's very clear what you do when the child is coming to your emergency department with a GCS-8, has a deficit, wide pupils, whatever. But what you do with all these children with only mild trauma, what you do with them. And we all have to have in mind that, of course, a CT scan does have the risk for a malignancy because of the radiation exposure. So there was this group around Kapperman. They published in 2009 in The Lancet this big study. They included 42,000 children. Of course, there was the control group in it. And they wanted to identify a group of low-risk patients. And for them, they wanted to see if it is possible to avoid a CT. And then they created this traffic light sheet. It's the pediatric head CT rule. I think you all heard of it. And they divided into children younger than 2 years and older. And the youngers, in the beginning, the red flashlight is actually the same as the GCS below 15. ALS means agitated, somnolent, not responding, or very slow responding, and repeat their questions a lot if they can speak, of course. If one of these points is there, you have to do the CT. And then again, the soft and hard risk factors are a little bit different depending on the age. And if one of these is present, you also have to do the CT scan. And here, very interestingly, they say the non-frontal hematoma, so parietal, occipital, wherever, is also a sign that there is something you have to watch. And if none of these factors is present, then you can skip the CT. And there are a lot of studies trying to see if this rule is really a good thing to use in the clinical routine. And retrospectively, it was like 30% CTs could have been skipped for the children. So I think it's a really good thing to have in mind. In spine injury, the NICE also have their recommendations. And the hard factors, again, is, of course, if there is a neurological sign that the limbs have some deficit, you should do an image of the spine. And especially because of the high head to torso ratio, the cervical spine is mostly needed. But also, if you cannot really assess the child, you need to know if there is something in the spine. So if the GCS is lower than 12 or it's intubated, you have to remember maybe there's a spine injury and you have to do something about it. Can do a CT scan, but of course, there are also in spine injury, plain X-rays you can try to do. And different other mechanism and different other diagnostic you can add. Like if you think there might be a vessel injury, you need to add an angiography, or you can do the MRI, of course, if you want to see more, and if you don't want to have the radiation. So I think to recommend always the CT really depends where you work. We already heard in the talk before, it's so different in the different countries and also in the different departments. In Switzerland, we are very fortunate. We actually can afford in every major trauma institute an MRI and in the emergency setting. So if the child is stable and does not show any sign of major trauma, that means it should be go immediately to the OR, we would try to get the MRI. And especially in the young, always think about the ultrasound because it's so easy. You can see a big hematoma and you can see even the fracture and the hydrocephalus. In my opinion, I'm not quite sure about the spinal sonography. I think there are a lot of very good sonographers, but also there's a lot of grayish in between. So you have to know in your department if the experience is very high. So what you do if a major trauma comes to your emergency, of course, this is from the NHS in Scotland, you have to follow the ATLS. And when it comes to the head, you should use some guidelines. Here are the nice guidelines. And if they are positive, you would do the CT scan or the MRI for the head. In the spine, some clinics always do the X-ray first. And then if something is suspicious, they add an MRI or CT scan, depending on the traumatism, depending on the clinic of the child. And as my last slide, I wanted to show you a screenshot of Professor Aurelia Perrault. She just gave a talk about this topic. And she showed us in this online talk her decision tree in her clinic in Ulm. And they divide their children into the one group with a GCS lower than 14. In these children, they always do MRI or a CT scan. And then they decide, depending on what they find, if the child can be transferred on a regular ward, IMC, ICU, or if they do have to do something. But this is will be talks later, so I will cover this. And in the children with a GCS of 14 or 15, they again look at all these hard and soft factors. In young children, of course, it's a little bit different. Hematoma, as I already mentioned, and again, ask the parents, is there something abnormal right now? And if the factors are positive, you make again an MRI, CT, or an ultrasound. And if not, you have to decide if you have to watch the child longer or not. And again, talk to the parents. Sometimes it's very difficult at home. Sometimes it's not possible to take a child just fallen down back at home with 5 other children. So always talk to the parents. Thank you very much.